women have a worse prognosis as per the outcome is concerned because of their atypical presentation. They are diagnosed very late, and the treatment offered are usually suboptimal many times. And the long-term outcome is very poor as compared to men. Even after a procedure, whether it's a bypass or a revascularization, the subset of MINOCA or INOCA is more commonly seen without much obstructive CAD. When we talk of obstructive atherosclerotic CAD, it's not entirely a benign entity. So they are not different. The outcomes are not very good even if it is a MINOCA or INOCA. So we have to identify the subset and treat. Then microvascular dysfunction presenting with ACS seen as a diagnostic challenge many times and very difficult to treat. Diagnosis is difficult, treatment is difficult, and of late we are getting much more data about microvascular angina or ACS in particularly young females, and they are not benign. So non-atherosclerotic causes of ACS like collagen vascular disease, vasculitis, aneurysm formation in the coronaries, Takotsubo cardiomyopathy, and cardiomyopathies of different origin are very commonly seen in women subset. So they are different actually. So if we take the MINOCA or INOCA, where we have a cardiac marker positive and they have ECG changes suggestive of a myocardial infarction, and MRI finding also suggestive of a myocardial infarction, sometimes it is Takotsubo also. So the overall incidence is around about 10 to 14% in different series in overall incidence. If you take female subset, it is more than 30%. So it's very high. So going to my cases, so these cases will be educative. This is a 34-year female aspirant for civil services, smoker, normal lipid, non-diabetic, normotensive, without any symptom, goes to an emergency with chest pain and collapsed outside the emergency, revived after a short CPR and thrombolized with TNK-TPA. Look at the ECG. This was the ECG. She was having a VF, thrombolized, and in a almost impending cardiogenic shock, shifted to our facility. This was the angio. You can see with the IBP was put, patient was initially stabilized, taken off for angiography. There is a proximal LED tubular lesion looking around about 60% to 70%. So this was the OCT done of this patient. One can see very tight stenosis. The thrombus has gone due to thrombolysis. This is after stabilization. You can see this is a large chunk of atheroma with a necrotic core, very tight disease of 1.68. And this kind of atheroma, whatever is the lesion severity on angiography, needs to be fixed because it's a proximal LED, a survivor of cardiac death. So we fixed the patient with a small stent, maybe 3.5 into 18 millimeter of Giant's alpine stent. The patient flow improved, and this was the final result, and patient stabilized. The final outcome was good. So my point is that all young patients are not benign. Sometimes you have to stent these patients. Moreover, you have to identify the subset which you can avoid a stent. Look at this patient. This is a case 2. This is 37-year female. She is working in a BPO, smoker, alcoholic, normal lipids, normotensive, non-diabetic, obese, and chest pain 3 hours duration. Comes to our emergency in the midnight with this ECG changes suggestive of ST elevation. When we shifted her to the CCU, during stabilization, the ST started settling. We took her on the table in the midnight. This is a thrombus sitting on the mouth of ostium of circumflex involving LED diagonal, large diagonal. And if at all you are planning for a procedure here, this is going to be a left main diagonal LED bifurcation in the middle of night. So I thought it's a young patient, let us go and do a thrombosuction, repeated thrombosuction. By then the patient hemodynamic little bit recovered, patient's chest pain gradually settled. So he gave me some time, and so repeated thrombolysis, vasodilators, stabilized, and the flow at the end of the procedure is like this. At this point, I decided to shift the patient to the CCU, took her again for a OCT next day morning. We can see the OCT run. I can run it because we have some time, I think. So otherwise I would have skipped it. You can see there is a clear-cut erosion which is very, very common in these patients with a large lumen, not non-obstructive lumen, and all white and mixed thrombus, red and white thrombus. So I decided the patient to left on medical follow-up without a stent, and this was the area. You can see 4.07 at the minimum luminal area, so it's a very adequate area for a flow. So DAPT, beta blocker and other thing. Follow-up angio after 2 months. Pristine looking coronaries, no problem except for some atheroma. So repeat a OCT run, and you can see very well healed plaque with a stable cap, and with statin this patient can maintain a beautiful long-term outcome, will be good actually. There is no concern about this patient. He has to modify lifestyle, and this was the follow-up OCT run of the same patient after 1 month or so. So this is a patient where it can avoid a stent. This is another 52-year female diabetic hypertensive dyslipidemic, comes with non-STMI with a troponin of 1400, grossly elevated troponin. You can see these coronaries. Coronaries are practically, coronary angio is suggesting nothing great. So we took her for a OCT evaluation. If you see in the allocranial, there is a OCT, there is some stenosis here, something here. So we wanted to see what is that. And we gave some nitroglycerin, the stenosis improved. If you see the run, OCT run, it's very interesting. Look at the distal segment, it's very, very clean. Gradually the artery is becoming small to 1.4, again goes up. So this is nothing but it's a coronary spasm distally. So it's absolutely normal coronary with 3-layer pattern. Coronary spasm in the distal tree. There is some atheroma here, and there is a erosion on the top. So proximally the erosion has caused the ACS. With this vessel is prone for spasm. So you can see the OCT analysis. Absolutely 3 layers of structure. Here it is 6.47 area, and it becomes 1.48 at the site of spasm. And if you go to the proximal segment, there is some erosion with thrombus setting. There is no plaque rupture. Again left this patient on medical follow-up, and this patient is just recently done, so I'll check a follow-up OCT maybe after 2 months. So this could be managed very well without a stent with imaging, intracoronary imaging. This is another interesting female diabetic 55-year. You see, got a pacemaker somewhere for 6 INS, dual chamber pacemaker, comes to our emergency with history of 2 episodes of chest pain previous week with 1 episode syncope. During CCU admission, the patient had a ST elevation in front of us in the monitor. The ECG was documented, and one can see a polymorphic VT-VF on the monitor. So this is a polymorphic VT with infralead ECG changes. So when we took her for angio, you can see a proximal very tight RCA disease. So we give some nitroglycerin. With nitroglycerin, to our surprise, this artery becomes absolutely normal proximally. So coronary vasospasm is not unusual in female particularly. So once you see this, give some nitroglycerin. But as this is a Akasaka's paper where they have demonstrated at the site of coronary spasm, many a time you will find erosion, plaque erosion with an atherosclerotic plaque. This is a study by Akasaka, and this kind of picture you get usually some thrombus attached to the endothelium. There will be some endothelial denudation. This is from NET. So in my patient, if you see, there was nothing much in the OCT. The lady who was having polymorphic VT-VF, you can see there is something here, some white thrombus attached to the endothelium, and you can see the endothelium is clearly denudated here. If we go to segmental analysis, I'll show you. You can see very well there is a healed plaque there, layered appearance suggestive of a healed plaque, and there is some endothelial irregularities all around. The endothelium is not looking smooth, and on the top of that there is a white thrombus between the catheter and the vessel wall. In the picture 2, OCT picture 2, this pointer is not working somehow. So This lesion, as it was causing VF, I decided to stent and stabilize this lesion because you have to pacify this lesion. You can have a recurrent event and these events are with sudden death. So we stented this patient with a long stent depending on the OCT finding, and the final result was good. 3 years post PCI follow-up, there is not even a single episode of ACS or any syncope or anything. A cardiac MRI was just done to rule out any myocardial cause for VF, and it was practically normal. So this is 60-year female, another case, very interesting. So we dealt with spasm, we dealt with erosion, we dealt with a stent atheroma in a young patient which was stented, and this is another patient subset of female patients we very frequently see. This is a 60-year female, mother of a resident, a little bit elderly for this subgroup, non-diabetic, hypertensive, non-smoker, chest pain of 2 hours duration with this ST elevation. And once she comes to us, there is a ST settling. So with nitrates and other things, we stabilized initially. The biochemical parameters were practically normal, and this was the angiogram. You can see very smooth looking LED, TME3 flow in the next day morning. There is a borderline lesion somewhere here. So we decided to take the help of OCT, and to our surprise, you see there is a spontaneous coronary artery dissection in this patient with a normal coronary limited to the branches, and the lumen is good, patient is asymptomatic, ST is settled, LV is preserved. So considering the clinical situation, imaging gave us the idea to manage this patient medically. This was the hematoma. You can see an area of 1.78 or something is compromised, but it's not causing any flow impairment. The patient is stable. So we decided to follow this patient. This is what the guideline also says. If your patient is stable, non-atherosclerotic SCAD without any lumen compromise, can be left on medical follow-up, beta blocker and one single antiplatelet. And at the time of discharge, the ECG, there was T inversion, and after the 2 months we took her for a follow-up angio. You can see grown up LED segment, and in the cranial view also you can see beautifully flowing LED. And if you see the OCT, there is significant resolution of the hematoma except a very small segment. This is a comparative OCT analysis. One can see this was a index event, such a compromised lumen, now totally healed up, and there is practically nothing, and this patient could be managed medically. This is similar SCAD, another female, 45-year, no obvious risk factor with chest pain, acute onset, ST elevation, ongoing chest pain. We took her for angio. This is a LED totally cut off. And if you see the IVUS, there is a pulsating intramural hematoma with, this is a true lumen, this is a false lumen. This means there is some communication happening between the lumen and the extraluminal space. This is very typical of that. And once we analyze, there is a dissection flap, clear-cut dissection flap, and the vessel lumen is compromised. So to our interest, we just did an OCT to confirm that, and the area was 1.4. There was ST elevation with the patient was having chest pain, ongoing chest pain. So this patient with a SCAD requires stent. So this is a patient needs to be fixed up. So we took a stent and fixed the patient with a stent, and the final result was good. And so there we saw two types of SCAD. One SCAD we stented, another SCAD we managed medically. So imaging gives you enough idea which patients to be treated how and when. And this is a most educative case, and my last case of the presentation. This is a 43-year female patient, very lean and thin, ACS, non-STEMI interval MI, 12 hours duration, dyslipidemic with a LDL cholesterol of 192. She comes with ACS, which is a non-STEMI. So she was taken up for angiogram, and you can see there is a critical LED lesion, very, very tight LED lesion involving a left main little bit, and circumflex osteum is borderline. So we thought we'll do a LED, left main LED crossover stent, because there is no space for putting a LED osteal stent. We did an IVUS. If you see the IVUS catheter is here, everything is dark around, and here also there is all dark around. These are nothing but necrotic core with a large lipid pool. So when you see this kind of large lipid pool with a necrotic core like this, and if it is more than 60 degree and 5 millimeter length, these are the patients they can lend into no reflow or slow flow. You should be very, very careful with these patients. Japanese, they use filter device for such patients. So we knew that our imaging finding gave us such insight. This is the histopathological correlation published. If you get this kind of picture, you get a large necrotic core with lipid pool, and they are prone for no reflow. So we did a gradual balloon dilatation, gave some nitroglycerin, SNP. After a balloon dilatation, you can see there is a no reflow already, slow flow. So it improved with SNP clearly. So we did a left main LED crossover stent. Immediately after the stent, the patient had a cardiac arrest with no reflow, and IBP was inserted. So we were clear in our mind what is happening. There is nothing wrong with the stent. There is nothing wrong with your procedure. The only problem is no reflow. So you have to treat that. Stabilize the patient's hemodynamic. Don't focus on your stent procedure. Don't go for aggressive dilatation. Don't put another stent. Don't do anything to circumflex ostium. Nothing is happening. It's a slow flow. So we knew that. So immediately the patient had a cardiac arrest. So we put an IBP, stabilized, maintained patient hemodynamic with 2 minutes of our support. The patient started having a TME3 flow. We did an IVUS run to see the stent is well apposed, well expanded. The circumflex LED carina is good. So no need for doing any further aggressive thing. Shifted the patient to the CCU, and after 2 hours, the patient was extubated and discharged in a routine fashion. So now, these are the patients. Attenuated plaque can trouble you. The other subset in female coronaries are Takotsubo cardiomyopathy. I will not go into details. These are the typical pattern. You can get an infarct pattern in your ECG. So if you are taking for a coronary angiogram, might as well you can do an OCT or an IVUS to see this normal, beautifully looking coronaries. So there is no erosion, nothing, no thrombus. You will get absolutely clean coronaries in Takotsubo. And MRI is the gold standard to diagnose this subset. Now coming to the coronary vasculitis, if you get such big aneurysm due to vasculitis, CT is a very good tool. You can get in angiogram also, you can get it CT. Even a smaller aneurysms, you are very well picked up by IVUS or OCT, and your treatment plan will be totally dependent on your OCT. You can optimize your procedure, whether to put a stent graft or reseal with a normal drug-eluting, drug-coated stent or something. The planning can be adequately done by imaging. So these are the subset, and coming to the biggest challenge is the microvascular angina causing ACS. For that, imaging has IVUS or OCT is not helpful. You have to take the help of a physiological tool like CFR, IMR to demonstrate microvascular angina, because it's not benign, and this is a common problem with females. So we have seen female subset, if they have microvascular angina, the outcomes are not very great, and they are not comparable to normal coronary subset. So to conclude my talk, MINOCA and INOCA is very common and relatively seen in young females. Intracoronary imaging, whether OCT or IVUS, identifies atheroma, erosion, plaque rupture, and guides to avoid stenting unnecessarily to a vessel. Medical follow-up can be equally beneficial and can be better in certain substates. SCAD is more common in young females, and an important cause of ACS, IVUS and OCT is very helpful to identify the subset and guide for appropriate interventions. IVUS and OCT can identify your lesion morphology, particularly like the last case, like attenuated plaque. You can predict no reflow, you can prepare the staff, you can prepare for the storm, and you can manage the patient very well. And non-atherosclerotic causes of ACS like Takotsubo or vasculitis with coronary aneurysm can be identified and managed by intracoronary imaging precisely, and microvascular dysfunction is not uncommon cause of ACS in female, and it's not benign, and it's better diagnosed by coronary physiology. Thank you for your kind attention.